Now recording. I do a slight introduction.
Sure.
Listen, I don't know all y'all different.
Clinical pharmacist.
No, ya tú estás. Vamos a calmar.
It's 11:30.
No sé.
Trying to make the best of it. All right, everybody. So we're gonna go ahead and get started. So housekeeping things. So you guys saw. So the cases were graded. So Dr. McCauley, comments you guys should be able to see. I'm gonna email like each group. So I'll put all four of you in an email, and with the copy of your case that has my comments on like what points you got, what points you didn't get, what you need to put in there. If any further questions about that, you guys can bring it to the exam review, or like later in the week we can talk because we don't have so much material left. So there's a lot of time to ask questions and do everything like that. Today we have adjunct special guest here. So we have Dr. Yame. She is a ambulatory oncology clinical pharmacist at Johns Hopkins Bayview. She went to Virginia Commonwealth University for her PharmD and then did her PGY1 residency at Johns Hopkins Bayview. She's also my best friend from pharmacy school, so she's very qualified. If y'all feel like I'm qualified, then she's qualified. If y'all feel like I'm not qualified, she's more qualified than me. Her GPA was higher. So she will do the smoking cessation, and then you guys will have full class today, an hour tomorrow, and then the individual assessment will be the second hour. So we'll turn it over to her.
Thank you so much.
Are you on?
I think so. Oh, great.
Okay. Thank
you so much for that introduction, Dr. Grigsby. Ooh, calling you Dr. Grigsby. Ooh. Have fun teaching. Do you need your laptop?
I do.
Come on down. That's right. What would you do without me? Whoa. All right. Well, like Dr. Grigsby said, I'm an ambulatory oncology clinical pharmacist over at Bayview. Part of my site is I do run a pharmacy learner-driven smoking cessation clinic, so hence my expertise in tobacco cessation that I'll be talking to you guys about today. Some of the other things that I do over at Bayview also include like working in our anticoagulation clinic once a week, give or take. I precept students and I precept residents as well. And I help coordinate the fourth-year API students with our local schools of pharmacy as well. So you, in the future, may get an email from me about rotating over at Bayview. So today we will be talking about tobacco cessation. For today's lecture, here are the objectives listed. I'll let you guys go through this in your own time, but these objectives are what your test questions will be based off of. So if any questions arise and you're not sure what to study for the test, this is it. This is your made fresh and wonderful study guide, essentially. So just utilize this to study and you'll be super successful on my portion of the test, okay? So to get us started with some background, so tobacco use is the #1 cause for preventable disease, disability, and death. So that includes diseases such as cardiovascular diseases, pulmonary diseases such as COPD, as well as things like lung cancer, as well as a lot of other cancers as well that we'll talk about. In 2019, about 50.6 million people in the US used a tobacco product. So whether that is cigarettes, chewing tobacco, cigars, cigarillos, anything that is tobacco containing, about 50.6 million people in the US utilize one of these tobacco products. And then in 2014, about 480,000 deaths were attributed to cigarette smoking. And a lot of these deaths were associated with some type of cancer, with the highest population being lung cancer. And then in 2015, the National Health Interview Survey reported that about 68% of adults who smoked wanted to quit, and then about 55% attempted to quit in that past year. With that statistic, a lot of those patients that want to quit just don't have the access to the resources or know where to get started. So as pharmacists, we are at the front line. A lot of you, you'll go to a community pharmacy and you'll see your pharmacist there. Or even in the hospital setting, there are a lot of situations that I touch base with my patients more frequently than their providers. So those are those instances that we can step in and assist them with tobacco cessation and assess if they're ready to quit and kind of set them up with the resources that are needed to make them successful. Now, when we think about tobacco cessation, we think about biological factors. So the biological factors include physiological factors, biologic effects of nicotine, and genetic factors. When we think about our physiologic factors, we think about the differences in absorption and metabolism. When we think about that, some of this is genetic, which we'll talk about a little later. And then some of these things that we think about with metabolism specifically is how patients experience those moods or symptoms that are associated with smoking. So some patients, you'll hear that they'll say, the first time I smoked, I was a little dizzy or a little lightheaded. I felt a little anxious. So those are pretty common symptoms that patients may discuss with you. But sometimes they'll experience other symptoms that we'll talk about. Some of the implications with nicotine include some of the things that I've listed here. So withdrawal, tolerance, which we'll talk about a little bit more, and then concentration of nicotine as well. So they're all somewhat interrelated. And we'll talk a little bit more about what does that mean. But those are important things to discuss. The other thing to keep in mind with absorption that I didn't mention is absorption is impacted by the type of nicotine product that is used. So there's a difference in absorption with cigarettes versus cigars. Some of that has to do with the way that the tobacco itself is processed. So the processing for tobacco for cigars is much different than that for cigarettes, and it changes the pH, which causes a difference in absorption. We also have to think about things nowadays that include e-cigarettes. So that's pretty common, especially in the younger population. We're finding a lot of younger aged adults that are vaping, and there is a difference in absorption with that as well because it is oil-based. And so that allows the particles within the nicotine particles to absorb a little bit better within the lung parenchyma. Any questions so far? By the way, I will ask if you guys have any questions pretty frequently. Please stop me whenever you need. I am a firm believer that if you have a question in the moment, you don't need to save it for the end. You're paying for this, so you should ask all of the questions you want. Okay, so a really important pathway to discuss is the dopamine reward pathway. Really important because it goes to show or explain a lot of that addiction component of nicotine for cigarette smokers and for tobacco users in general. This is not specific to just tobacco use, so keep in mind that a lot of addiction in general, this is a very similar pathway that they utilize, but some of the binding is a little bit different. With tobacco use or with nicotine use, nicotine will enter into the brain through the blood-brain barrier, and then it will stimulate the nicotinic receptors, nicotinic acetylcholine receptors specifically, into a specific area that we call the ventral tegmental area, or VTA. Within the VTA, dopamine is released. And when dopamine is released, it goes to the nucleus accumbens, and then travels also to the prefrontal cortex. In this general area is where that dopamine reward pathway kind of begins. And with that dopamine pathway, that is where this addiction component or behavior is learned. So with repeated use of tobacco or of nicotine, that area is constantly stimulated and triggered, which causes a lot of this acquired behavior. So essentially, this is where people get into this addiction, and this is the reason that it makes it very difficult for patients to quit, because they're constantly having a release of dopamine, right? And what happens when you have a release of dopamine? How do people generally feel? Yeah. So it's a lot of like dopamine causes feelings of pleasure, joy, happiness, right? And so with that, patients are always like, oh, I feel really good or really comforted when I smoke. They associate it with a lot of relaxation, or in times of stress, they'll say like, this really is comforting to me. Part of that is associated with a learned habit. They'll associate good times that they had growing up, depending on age with smoking, but a lot of it has to do with this dopamine reward pathway as well. Any questions so far? Great. So when we talk about the nicotine biological effects, we need to understand that nicotine is both a stimulant and an anxiolytic, which I know I mentioned earlier that some patients will say that they experience feelings of like anxiety and their hearts racing the first time that this happens. This anxiolytic effect doesn't necessarily happen the very first time. It's that stimulation component that takes over. So over time, you'll hear patients say that it helps me with my anxiety, and that is because it does have that anxiolytic property associated with it. Nicotine readily crosses the blood-brain barrier, and that's what makes it, be able to bind in that dopamine pathway mechanism that I just talked about. And it also can bind or cross over the placenta. And that's why you hear a lot of times people talk about it's really important for pregnant moms to quit smoking because of the impacts and the effects that it can have on the fetus. Things that I've mentioned earlier is it does bind to the nicotinic acetylcholine receptor within the brain, which causes that release of dopamine that we talked about. Now, when nicotine binds and this effect occurs, right, there's a physiologic effect that happens as well. So what happens is essentially things that occur physiologically include an increase in heart rate, an increase in blood pressure, an increase in your metabolic rate. It can cause vasoconstriction, skeletal muscle relaxation, and then an improvement in attention and concentration. So these are a lot of things that, we talk about those cardiovascular risks associated with smoking. This explains a lot of it. But it goes to show a lot of the issues with the withdrawal component that we'll talk about later as well, and what makes it very difficult for patients to quit as well.
How long would the concentration effects last? Is that like a very short term?
Good question. It depends. The longer they smoke and the more that they smoke, the higher the concentrations. So if it's someone that's like a brand new smoker, smokes 1 or 2 cigarettes a day, the effect doesn't last nearly as long. But obviously with our patients that smoke 1 or 2 packs per day, and it's in a continuous effect, that's continual assault to the cardiovascular vasculature. So to your, which can cause that long-term vasoconstriction. And it's your body tries to compensate, right? When we talk about high blood pressure, it will try and compensate to lower it. It essentially will take time to reverse it depending on how long that they've smoked. And sometimes that damage is more permanent. Does that make sense?
It does make sense, but I was thinking more like how long lasting. You said that it depends. But just to have an idea, you have like a ballpark idea
of concentration. So just like from a short-term perspective or long-term?
Well, not concentration in the sense, but like in the attention and concentration sense.
Oh, in terms of how long does that take for it to reverse? Oh, the focus itself? There's a couple of pieces that it's dependent on. It's a little bit different for everyone. Part of that has to deal with the tolerance that we'll talk about, right? Because the dopamine, as you go on, you won't feel like you have the same effect. And so patients will go through what we talk about, what we call withdrawal, and they lose that attention. So it could be anywhere from 4 hours. It could be about 2 hours for some patients. It really depends on their cigarette consumption from that perspective. Does that make sense? Okay, great. Any other questions? Okay. So with that biological effect, we talked about dopamine as a neurotransmitter that's affected. There are several other neurotransmitters that are involved in this biological effect as well, including serotonin, norepinephrine, acetylcholine, glutamate, GABA, and beta endorphins. Essentially, all of these neurotransmitters, what they have in common is that they make people feel good, right? And you'll also hear, like, for example, with norepinephrine, a lot of patients that smoke say that they have appetite suppression, it's because norepinephrine is involved in this pathway. So you'll hear a lot of patients will say, oh, I quit smoking, but I feel like I'm eating like a horse. I've had a lot of patients that will actually turn to food. So in those instances, it might be that we have to recommend that the patient see the dietitian to help aid in those. That one piece that might be difficult for them to get over on their own. But with these neurotransmitters, the number one or main one that we really think about is dopamine. So that's going to be like the most important neurotransmitter in this pathway, and is what is implicated in that reward feeling that patients get, and is why the biggest reason that the addiction really takes over, and why it's very difficult for patients to quit. There's also various receptors that are affected, but the main one that I want you guys to be aware of is alpha-4 beta-2. It's the nicotinic receptor. And so you'll find, we'll talk about it later, because one of the drugs that we'll talk about actually binds to the alpha-4 beta-2 receptor, but that is the primary receptor that's affected when it comes to nicotine use. So the nicotine metabolism and elimination. So nicotine is primarily metabolized in the liver, and it's primarily metabolized by a CYP enzyme, and that's specifically CYP2A6. Later on, we'll talk about like CYP enzymes from drug interactions perspectives. Keep in mind that this is the primary, CYP2A6 is the primary CYP enzyme that metabolizes tobacco or that nicotine component, but there is another CYP enzyme that we'll talk about later, and I'll explain kind of what that looks like. With the metabolism of nicotine, the metabolism or half-life of nicotine is about 2 hours, give or take. And it's metabolized to its metabolite, contamine, which is, and the half-life for that is about 16 hours. Now, often with patients, especially as they're going through their nicotine treatment or tobacco treatment program, some tobacco treatment facilities will utilize contamine as a way of measuring when a patient last had a cigarette. So the half-life, as I said, is about 16 hours. How many half-lives does it take for this to completely be excreted, or that we expect it to be gone? I heard something. 4 to 5 half-lives, exactly, right? So that's about, give or take in this case, 3-ish days. And so for those facilities, they will do this utilizing either a urine test. There's also a hair test that you can utilize as well. And in those instances, they'll measure that. It'll be able to tell them if a patient has had a cigarette within the last few days. There is another metabolite that can be measured. We don't use it that often because contamine is the primary one that we'll utilize. So I won't talk about that other metabolite. Now, nicotine is excreted through the kidneys. So that's why they'll measure, like I said, we'll measure the contamine through a urine test. Now, the metabolism of nicotine can vary. So it's dependent, there's a genetic component that we will talk about, but it can also be dependent, as we said, that this is metabolized through the liver. So patients that have any type of liver disease, the metabolism is a little bit slower. And then patients that have a certain type of genetic component that we'll talk about in a couple of minutes, that will also cause a slow metabolism of nicotine in those instances. And so this can lead to higher concentrations and extended durations of nicotine in the system.
I have a question
Yeah.
about contamine.
Mm-hmm.
What type of activity does contamine have? Is it once it's transformed to contamine, it's pretty much inactive, or would it have like psychoactive agent?
Good question. Contamine is inactive. So once it's metabolized into contamine, the only benefit of that from a smoking cessation perspective is it can tell you if they have or haven't smoked. Okay, so tolerance. I mentioned tolerance a little bit earlier, and I'm fairly certain a lot of you know what tolerance is, but just to give you a general definition, tolerance is essentially the need to be given a substance at a higher dose in order to attain the same effect that you had when you utilized a substance at a lower dose. So, for example, if a patient starts out smoking 5 cigarettes a day and they say, I'm not getting that same pleasure effect, the same joy that I have when I normally smoke 5 cigarettes a day. And they up it and they say, okay, so now I'm going to double it and smoke 10 cigarettes a day. And then at that moment they say, oh, I'm having that same effect. That is an indication of tolerance. It's saying that what they were using before is no longer providing them the same satisfaction or the same effect that they had when they used that lower number of cigarettes. And as part of the reason that it can make it quite difficult for patients to quit is just dependent on their tolerance level. Factors that influence tolerance include the duration and the amount of nicotine exposure. So like I mentioned, the number of cigarettes a patient can use, how long have they been smoking. So someone who has been smoking for 6 months is going to have a different tolerance than someone that's been smoking for about 20 years. And so that's something to keep in mind. The nicotine product that they're utilizing can also have a factor as well, because it can affect the amount of nicotine exposure a patient has. Other things to keep in mind: pattern of use, so how they use it, what patterns they've kind of created over time, and then environmental factors. So these include things like having others around them that smoke. Right, that can be an environmental factor that can affect their tolerance, because inherently a lot of patients will say that is a trigger for me, and so for them, it will cause them to likely smoke more and can affect their tolerance habits as well. Now, there are 2 types of tolerance that we think of. We have the acute tolerance and the chronic tolerance. Acute is essentially initially you are satisfied by your current smoking, and then all of a sudden you have a loss in the satisfaction over time. It'll decline. But it's in that acute setting. Chronic is, essentially you're smoking to avoid having withdrawal. So that if you don't smoke, you are going to feel really crummy and you're going to start to feel those withdrawal symptoms. And in those instances, that is what's considered a chronic tolerance. And so they're smoking in order to keep up with what they have had. And so that's what we call in smoking cessation, where those things are like habit forming versus like what we would consider compulsion, which could be associated more so with like that acute tolerance, where we're compulsively smoking so that we don't lose that satisfaction. Whereas what we've learned or acquired over time, where we are very regimented. Like I have patients that say I have a cigarette with coffee, 1 with lunch, 1 with dinner, 1 while I drive, but they're very regimented. Like I do this because I'm used to doing this, and it's also me subconsciously trying to avoid having withdrawal symptoms.
That's it.
Yes. Now, I've mentioned withdrawal symptoms a couple of times. So what are some of these symptoms? These symptoms include anxiety, insomnia. A lot of patients will say it's very difficult for me to sleep. And so in those instances, when they say it's hard for them to sleep, the first thing that they think of is, I want a cigarette. I'm awake. I might as well have one. So that's something that they might have to battle as they're going through their tobacco cessation. Patients will express that they feel restlessness. And they may feel that increased appetite. Remember, I mentioned that norepinephrine will cause that appetite suppression. In this case, they no longer have that release of norepinephrine. And so that can cause an increase in appetite. Some of that also has to do with some other acquired factors, but the biggest one is like that lack of norepinephrine. So that can cause an increased appetite. They can also have difficulty concentrating. So remember, we said that tobacco use can cause a better concentration in patients. So in this case, when they're going through withdrawal, it's very difficult for them to concentrate. Yes?
I was thinking that nicotine would be classified as a stimulant.
Mm-hmm.
So when a patient is saying, I can't sleep, and is taking a stimulant, how does it sleep?
Their body gets used to it. So essentially you're correct. So when they first start smoking, It's been the first couple of weeks, first few months. You're correct. They may have difficulty sleeping. But they may not associate it with. They may not associate it with nicotine smoking. And every person's a little bit different. But initially, they may have a little bit of difficulty sleeping depending on when they have their cigarettes. But over time, your body learns these habits and gets used to it, and they can overcome some of that difficulty with sleeping. And then it becomes the opposite end problem, because when they quit, they feel like, they'll tell you, I felt like the cigarettes helped me sleep. That's not necessarily the case. It's that they just got used to, or their body got accustomed to that level of stimulation, and they're able to sleep through it. It's very surprising, and it's a very, very interesting concept. But essentially, your body will create its own homeostasis on how it can compensate and match that situation. So initially, they'll have that super stimulant, very high energy feeling. Over time, that goes away. Some of that's tolerance, some of that's metabolism components, but typically patients are able to sleep through it at nighttime for the most part. I have very few patients that tell me they have difficulty sleeping initially. Does that make sense? I know it's a hard concept to understand, but the body is an interesting thing. A lot of times it will find a way to compensate for itself. Difficulty concentrating when they quit, and then irritability. I hear a lot of patients say, I'm super irritable because I'm just trying to quit smoking. It's very common. And their families will say they have become very grouchy and very mean. All of these withdrawal symptoms are very short term, and over time they will dissipate, but it's assessing and assisting the patient through some of these withdrawal symptoms. That's why we utilize pharmacotherapy agents to help aid in this process. Genetic factors. So as I mentioned, there are genetic factors that can cause variations in metabolism. So patients that have a genetic polymorphism of CYP2A6 2-star, 3-star are considered slow metabolizers. And so often this is associated with decreased cigarette consumption because obviously their nicotine concentrations are a little higher for much longer. So they don't need to smoke as many cigarettes in order to have that same effect. And with this lower cigarette consumption, these patients often have a higher quit rate because it's easier for them to quit. They are starting at a much lower cigarette consumption number. And so typically we can overcome and battle that with some cognitive behavioral therapy, which we'll talk about. Typically this polymorphism is seen in non-smokers. So a lot of times it's patients that they'll try smoking maybe once or twice, but they'll say, I felt really, really sick. I felt nauseous. I felt really very, very anxious. Because they don't metabolize it in the same way that someone who doesn't have this polymorphism, those side effects or those symptoms that you can see with cigarette consumption hits them a lot harder. And so they're the type that tend to stay away from smoking in general. They might try it, they just don't feel good, and they just associate it with those symptoms and won't smoke, period. All right. Knowledge check. I have a few of these embedded into the slide. So which of the following neurotransmitters is released after nicotine binds to the nicotinic acetylcholine receptor? A, adrenaline, B, dopamine, C, oxytocin, or D, glutamate? Perfect. You guys are listening. Love this. Yes, dopamine. I've talked and harped on the dopamine reward pathway. Dopamine's, like I said, the main neurotransmitter the main neurotransmitter that is released that we really care about in this pathway. Of course, like I mentioned, there are several others, but this is the big one that causes that feeling of reward. Great. So we're going to go through the tobacco products. I want you guys to understand just the general differences in the tobacco products. For the most part, we're going to focus on inhaled products, but do know that there's several other products that are out there for tobacco use. I'm not going to touch on them, mainly because the goal of this is for you guys to understand the smoking cessation component of this lecture. Certainly, if anyone has questions about some of those other products, I'm happy to talk about them. But for the main purpose of this, we'll just talk about the few inhaled products, okay? And so I'm just going to provide you with a few definitions. So tobacco, it refers to any tobacco product. And so that includes things like cigarettes, cigars, hookah, and smokeless tobacco. And there's several others out there as well. And then smoking is, as you guys know, is the inhalation and exhalation of a smoked product by combustible products such as cigarettes and cigars. And then this differs from vaping. So smoking has to do with combustion. Vaping is aerosolized. So it is different in the way that its delivery system. And so that's what makes the absorption of these products a little bit different. With vaping, it's an electronic nicotine delivery system. Sometimes you'll hear this referred to as ENDS products that delivers aerosolized nicotine. And so for that reason, it enters the lungs a little bit different. It can penetrate the lungs a little better than what you will see with traditional cigarettes and cigars. With tobacco products, we have several different types. There are cigarettes that you guys have probably, traditional cigarettes that we've seen. Cigar products, there's several different types of cigars. So there's what we call little cigars, and then what you would consider like a traditional cigar, much larger in size and has a much higher content of nicotine or tobacco wrapped inside that cigar. Typically, those cigars have about what you would see in one pack of cigarettes. And then we have pipe tobacco, and then we have hookah. And then there's smokeless tobacco and snus, which these are essentially what you'll hear people talk about as chewing tobacco. And then we have the ends that we talked about, which these are our electronic cigarettes, or of what people call vaping. So that includes things like tools, e-cigarettes, and all of our vapes.
And snooze is like the leaf form?
It's a little packet. And so snooze is essentially, you'll see, oh gosh, what's that brand called? It'll come to me, I've seen it. It's a newer brand that's come on the market, but essentially snooze is like, it's these packs of cigarettes that they're wrapped into like a white packet. It's very small and it goes in between the cheek and gum and dissolves through the cheek. Yes, the Zyn. Gosh, I don't keep up with those things. All of my patients are smokers. None of them use Zyn. Zyn is actually more common with the younger population now. It's all about how they advertise and things like that. But yes, the Zyns, they absorb and they actually make cuts in the mucosa, and that's how the absorption occurs. Okay, so anatomy of a cigarette. So fairly certain you guys have probably all seen a cigarette, but does anyone know the anatomy of a cigarette? Okay, that's a good thing. I know that brings me joy. That means you've hopefully not really smoked them ever, which we love that. And so with the cigarette, we have our tipping paper, then we have the air venting holes, which, let's see. Oh, yes, the air venting holes here allows air circulation. The idea of the air venting holes is that it's supposed to decrease the concentration of nicotine that a patient absorbs by allowing air to filter through. That's not true. It doesn't work. Patients know how to get around that. Essentially, patients can cover up those holes and there's no longer that air filtration that happens, which means that they can get a higher concentration of nicotine into their system. So the air but there are technically air ventilation holes. Then we have the rod, of the cigarette here. Within the rod, there's porous white paper here. Within that is the tobacco itself that is inside the cigarette. There are about 9,000 chemicals, depends on the cigarette company, brand, and where you buy them, but there are about 9,000 chemicals inside of a cigarette within that tobacco. I know, it's appalling. This is part of the reason that it makes it very difficult to regulate and very difficult for people to quit, because the intention for cigarette companies or for tobacco companies is that people will smoke these continuously. So they try to make sure that the chemicals within them will aid in addiction. Nicotine itself is certainly addictive, but there are other chemicals that you can add to a cigarette to make them, to increase the absorption, which can lead to higher addiction properties. And then obviously there's the ash at the bottom for airflow to go through for the cigarette to just kind of break down over time. And so that is the general anatomy of a cigarette. Now with cigarettes, as I mentioned, there is a variation in pH between, like I said, our cigars and cigarettes. I'm going to focus on cigarettes in this lecture. And so for the pH of cigarettes, it tends to be more acidic. And this has to do with the way that the tobacco itself is processed, and it causes this acidic environment. And so when that happens, because the acidity of the cigarette itself, it can allow for higher or better penetration into the lungs. There are vent holes, like I mentioned, which is meant to allow air into the filter, which is supposed to decrease or dilute the cigarette smoke, right? And when they study this, the idea was that cigarette companies a long time ago were told that they have to figure out a way to make this what they consider like a lighter cigarette, so that patients, aren't as addicted. There has to be a way to filter out some of this addictive property. And so the tobacco company said, sure, we'll add air ventilation holes with the idea that this will help dilute the cigarette smoke. And so when they test it there's a machine that they use. When they test it, it passes, right? But the ventilation holes, the location of them is where a cigarette holder would hold the cigarette. So their fingers are now blocking those vent holes that were there to help dilute the cigarette smoke. And so therefore now it's no longer viable or useful. It's now kind of useless for those to even be there. And then the filter, like I said, is fundamentally like just defective and deceptive. So like I said, the smokers can compensate by covering the holes. They can also take what we consider like a bigger puff, so a larger inhale, to overcome that as well, so that they receive the same concentrations as they would even if they, let's say, they don't cover the ventilation holes. To take a bigger puff, they'll have the same concentrations, same yield of concentration of nicotine in those instances. Okay. So, question for you guys. Is nicotine harmful for the body? Why do you say no?
It's a natural neurotransmitter.
Okay. Yes, like that. Anyone else?
I think it's like the byproducts of smoking is really what causes the damage.
Yes. I heard something else in the back.
I would say yes and no, depending on the quantity.
Okay, sure. So you're thinking like nicotine poisoning? Something like that?
In the case of like smoking, excess of nicotine exposure leads to dependence.
Leads to what? I'm so sorry?
Dependence, addiction.
Sure.
Yeah, so in that case, I would say it can be harmful.
Okay, yeah. I see what you mean. So I agree with the two folks that said it's not harmful. So it's not harmful. It's addictive. You're correct. It's addictive. But everyone, I bet, in this room has their addiction. Some people probably go home and have a pint of ice cream every night. That's an addiction. It's delicious. Could lead to diabetes, but like in moderation, is it really harmful? What?
Some people can't drink water.
Yeah, that's an addiction, right? You can say that.
Can't
Right.
drink water. It must have a taste.
Hydration is important. I agree. So everybody has their vice, right? Some of them are healthier and some of them aren't. But nicotine itself, it's not harmful. It's just addictive. It's all of those byproducts. So I told you there's like 9,000 byproducts, give or take. Depends on who you ask. Some say about 7,000. But all of those byproducts, that's what's harmful. Those are the things that are associated with increase in worsening cardiovascular risk, increased likelihood of development of various cancers. And they all come from those byproducts. But nicotine itself, fine. Like, is it addictive? Like I said, yes. But is it anything else? No, not really a big deal. So that's why I tell my patients when we're going through smoking cessation, a lot of them say, I really find this nicotine patch helpful, but the box says I have to quit in 2 weeks. And I tell them, no, you don't. You could be on that patch for the rest of your life. There are studies that have shown that the harm of those is very low. Of course, it depends on the side effect profile and what the patient's experience, but if they're tolerating it very well, they could be that on that for the rest of their life and be fine. And so, like I said, the nicotine itself, it's addictive, but it's not harmful. And in those instances, I'd rather have my patients be on a patch forever and know that they're not getting those toxic additives that are in cigarettes itself than to not have a nicotine patch and ultimately relapse. So we want to be mindful, not saying everybody should be on some type of nicotine replacement product forever, but when we look at the impact itself, nicotine itself, as much as it is addictive, it's not harmful to the body. So we want to be mindful. How can we aid in their tobacco cessation or smoking cessation in general, while making sure that we eliminate these things that are just bad for them in general.
Is nicotine the only thing that is getting them addicted? Oh, I assume there's a psychological component. Like, chemically speaking, is nicotine it, or are there other chemicals that are actually chemically making them dependent?
Yeah, good question. Nicotine is the only thing that's making them dependent. That's it. Everything else in there is truly just additive. Some of them, sometimes they add like an additive. For example, in New York, if you buy a cigarette there's an additive that is in the cigarette that allows the cigarette to essentially, if it's burning, some people will just leave it in the ashtray and let it burn. They were seeing an increase of apartment fires and house fires. So there's a component in there that will actually put out the cigarette if it's left in the ashtray. And that also increases the addiction property because patients now have this X amount of cigarette left that they can just relight. Versus my patients that are like, I just let it sit in the ashtray and I might only smoke a fourth of it. There's a difference in the amount of nicotine that they've actually have absorbed into their body. And so it's those additives that it just depends on what they're looking for, but they'll add it for various purposes. All right, I think it's speaking on cigarette components. So like I said, there's over 7,000, so 9,000 chemicals in a cigarette. Some of these things include acetone, carbon monoxide, ammonia, something called polycyclic aromatic hydrocarbons, or PAHs, which induces mutation of the p53 gene, which is a major cause of lung cancer. And so we'll talk about this later, but these polycyclic aromatic hydrocarbons also cause some issues with drug interactions. And we'll talk about those a little bit later, likely tomorrow. But they lead to lung cancer. And then we have formaldehyde, butane, benzenes, or benzopyrenes, which damage the cervical cells found in the cervical mucosa, which can lead to cervical cancer. We also have acetic acid. There's acyclamines, which can cause damage to the bladder cells, which can lead to bladder cancer. We have arsenic, which is never great. And then benzene, which is essentially can damage the immune cells, which can lead to myeloid leukemia. And so being mindful, these are just a few of the components that I wanted to point out. But what you can see here is a lot of these byproducts lead to cancer. They can cause mutations in your cells, which any mutation in the cell can essentially lead to some type of cancer down the line. Any questions about that? Okay.
So there's one I was interested in. There is this snuff.
Mm-hmm.
We didn't talk about it when we're talking about nicotine products. Is it that it's tobacco products? Is it that it's not something that is commonly used around here?
No, it is. Snuff is another type of smokeless tobacco. So for the purpose of this lecture, I just didn't include it because the goal of this is more so from a smoking perspective. But snuff is definitely still used. I typically see it more so in the older patient population because that was something that was more common during that time. People have switched to the snooze versus the snuff. People are a little bit wary about snuff so snuff is essentially inhaled through the nose. You just sniff the tobacco, and that's how it enters into the
Like the stigma.
The stigma. The snuff, most of the time snuff is sniff. There's chewing tobacco that you can also put under the tongue as well. And some of it's the stigma, some of it's like it's not comfortable. No one likes things going up their nose. Like it just it's not exciting.
So in the light of, why I was asking like that, in the light of the fact that nicotine, not the problem, snuff will not have any other additives.
It does. Because some of these additives are added for, like I said, for the addictive property. Some of it's to stabilize nicotine itself. Some of it's to increase the absorption. It all depends, but it's not straight nicotine. They never put straight nicotine. They always mix it with something for absorption component, but also from a safety's perspective as well because of the mucosa. Nicotine, like I said, nicotine is an irritant to the mucosa because technically it's poisonous. And so if you were to use like the actual straight plant, that's why they have to process it in a certain way. And that's part of the reason they add some of the additives. Does that answer your question, I hope? Yeah. Okay, great. Okay. Knowledge check. So which of the following is a way that smokers can use cigarettes with a filter? Let me start over. Which of the following is a way that smokers using a cigarette with a filter can increase the yield of cigarette smoking? Select all but apply. A, continue to smoke the way that they have been, and the yield does not change with the filter cigarette. B, they take shorter puffs. C, they take bigger puffs. D, buy a different cigarette brand with a filter. Or E, block the ventilation filter holes. Perfect. Yeah, C and E. So they can take bigger puffs so that they can have that same concentration like I mentioned, or they can block the ventilation holes as well, which will decrease that airflow into the cigarette, which can cause same concentration as well. Any questions about that? So going through some of the other tobacco products, we have cigar products, which by definition is a cured tobacco wrapped in a tobacco leaf or in a wrapper that contains tobacco. So essentially cigars are tobacco with a side of tobacco. Cigarettes are not that. It's paper, it's tobacco wrapped in paper. Cigars are obviously tobacco with tobacco inside. With these, the pH is more alkaline. Once again, this has to do with the way that the tobacco leaves are processed. For that reason, because it's more alkaline, it can't penetrate into the lungs as well. Typically, the penetration occurs more so like in the esophageal pathway. So often I actually see patients with who have smoked cigars in the past, they develop esophageal cancer, which is not nice or comfy. So like I said, most of these absorption will occur in the esophagus. With the cigars, like I mentioned, there's a few different types. There's the large cigars, which are, they're also considered premium cigars. Some people will mention them as Cuban cigars, but they contain about 5 to 20 grams of tobacco, which is essentially 20 grams is about how much you would see in one pack of cigarettes. And then we have our cigarillos or small cigars. They're shorter and wider than large cigars, and they contain about 3 grams of tobacco. They are often available in a variety of flavors. So there's like vanilla and strawberry and green apple. There's like various different flavors. So as you can imagine, it's more so utilized in the younger population. Along a lot of younger adults or teens will find that more attractive because there are different flavors. That's part of the issues with like vaping. They can buy the vape juice in different flavors, and it's advertised in such a way as well because the user finds it more appealing because they think it tastes better. And then we have little cigars. And so these are tobacco. This is tobacco wrapped in paper that contains tobacco. It's less than what you would see in a premium cigar or a large cigar, but it still has like some components of cigar in it. When you see the wrapping paper, it kind of almost looks, when you look at a little cigar, it almost looks like a cigarette. But there are, like I said, these differences that the tobacco is actually wrapped in paper that contains some level of tobacco itself. It's usually about 1 gram of tobacco, which is pretty equivalent to what you would see in a cigarette. And then it's meant to be smoked like a cigarette. However, keep in mind, like I said, the pH is different, so the absorption into the lungs isn't as great. Something to keep in mind. And so I've seen an uptick in the use of these little cigars. There's several reasons. One of the bigger reasons is the cost. Does anyone know how much a pack of cigarettes costs these days? 10? Yeah, it's about $10, give or take. Some people will cross state lines to buy a carton. It's cheaper when you buy cartons, and I've been told Virginia's a state to go to by my patients because they say it's a little bit cheaper there. But yes, about $10. A pack of these little cigars, one, they can buy just a few at a time because they'll break a pack. But the other thing is that typically a pack for the little cigars is anywhere from like $3 to $5. And so because the cost is a lot cheaper, I've seen an uptick in my patients switching to this because they feel like I'm getting the same effect to some degree, right? They're still having this dopamine reward pathway, but I can do it for much cheaper. So I've mentioned, and we'll talk more about the pharmacotherapy and treatment process maybe today. But something to keep in mind about this is that the way that we treat people who utilize cigarettes versus cigars can be a little bit different, and it's because more so that the data is lacking. We are just guessing, not because this is all tobacco. It will work to some capacity, but sometimes with my patients that utilize the little cigars, we have to be a little more creative.
So pH not aligned means that absorption is reduced.
Into the lungs.
Yes, but it's the same effect.
Because it can still cross the blood-brain barrier.
So it's still enough to generate that kind of effect.
Yes, there's still enough to generate that effect. But the absorption into the lungs differs, and the reason that's important is because the absorption into the lungs allows those chemicals that I discussed to penetrate in and cause those DNA changes, which can lead to the cancers and things that I talked about, specifically lung cancer. That's why we care so much about that change in pH.
So this is safer and it's cheaper.
Not necessarily safer, but it's cheaper because this still contains a lot of additives, and it's not necessarily associated with cancers. I can't tell people that you're going to get lung cancer because we know that it doesn't penetrate into the lungs the same way. But anything that's inhaled to the lungs is just damaging, regardless of what the components are. I can't say what's in these little cigars because they are not ever very honest. And there's not as many studies associated with the cigars as there are. The point of the cigars is that it's not supposed to be inhaled, but these are smoked the same way. So for that reason, you want to be mindful. I can't say it can cause cancer. It can likely, especially because it's a lot of it is into the esophagus, it can cause changes in the DNA there. And so certainly you are at higher risk of developing esophageal cancer. Does that answer your question? So that's the part that doesn't make it any safer than nicotine or as cigarette smoking.
but the chewing are less now, right?
Chewing tobacco also has its ailments. So chewing tobacco has a high association of mouth cancers. So like you can have a growth in your tongue. Like I have had patients that did chewing tobacco and they developed essentially like a tongue cancer, so they had to cut out their tongue. That's the only way to get rid of that. Yes, it's not fun. and patients tend to have really bad teeth because it can cause really bad gingivitis and gum disease. So also no better. Same association, similar toxicity. It's just differing in the type of disease that you could get or association. And keep in mind that this also still has those cardiovascular risks that I talked about. And there's also a component of like concerns with diabetes. We're not going to talk about that in this lecture, but tobacco use can cause insulin resistance. So we want to be mindful. This is just in general, tobacco use is not great for our bodies. Okay, so hookah. Hookah is essentially a special tobacco. So it utilizes water, a water pipe with tobacco coming in many different flavors. Things such as cherry, grape, chocolate, mint, apple. Have a lot of different names depending on cultural background. And the problem with this is that it has many of the same health risks as many of the other smoked tobaccos that I talked about. And for that reason, our goal is to get people away from hookah. However, hookah is very much targeted towards a younger population these days because of all the flavors that it comes in. In 2007, about 1 in 13 students in the U.S. were found to smoke hookah, and then about 1 in 8 young adults in the U.S. were found to smoke hookah. So for that reason, it makes it difficult because, right, students generally don't, for them, because it's utilizing water vapor, the thought is that it's healthier. Like it's not much of a problem because this is water. Like I drink water every day. Why is this a problem? But it does still have many of those same health risks that I talk about, the cardiovascular risks, those diabetes risks that I mentioned. It can still cause those pulmonary risks, so COPD, emphysema, things like that. So it's not really any better. It can still also be associated with cancers and things like that. So we want to be mindful, and that's why the goal is to get people to be aware that these are no better. They're equal and the same, but also being mindful because some of this is, some of these things are cultural, right? Like some of this is something that is embedded into someone's culture. So you want to be mindful and tactful in the way that you talk about it and present it, as with the health risks and whatnot. Any questions? Great. All right, and then we have our electronic nicotine devices, or ENDs. So these are battery-powered devices that vaporize the liquid solution to vapor. It's most commonly used in tobacco products used among the youth in the U.S. So like I said, things like, bless you. Being a lot of the vaping in general is more so aimed at young adults, and because of the various flavors that you'll see inside of these products that are used, it's not just your traditional menthol, which used to be the additive component that patients found like back in the 70s, 80s, that people would use and say, oh, young adults are like, I'm into the menthol. It's a different flavor than your traditional cigarette. Now we have all of these fun flavors, strawberry, grape, things like that. The intention when these ENDs devices were created was to assist with smoking cessation, but the problem with it is that essentially people move from one vice to the next. So they essentially move from one smoking device to another smoking device. The purpose of this was to help them get down to, there's varying concentrations with these vape juices. The point was for them to get down to a 0% concentration and then eventually just completely quit using it. So it's supposed to be very short-term use. The problem is that people have gone from utilizing cigarettes to utilizing this full-time, and they think that it's healthier. It's not. It's the same, and we actually have less data. So it's kind of hard to quantify. Certainly now we have a little bit more data to say whether or not we think short-term, long-term is useful. But it's still something that's inhaled into the lungs. It still has its health risks associated with it. For example, there's something called like popcorn lung. Essentially, it damages the lung mucosa, and it's not reversible, which can lead to decreased lung capacity and oxygen saturation. Other things that are I think I died. That's okay. I'm scared of this. Other things that are in. Can you guys hear me? I'll figure this out in a minute. Other things that are in there include glycerin, water, and propylene glycol, and that can affect the penetration of the nicotine into the. Yep.
When nicotine is at 0%, let's be a risk.
What's the what? I'm sorry.
The nicotine there is 0 to 36%. If it's at 0, it's to be a risk.
In terms of a health risk?
Yes.
Yes, because it is something that is inhaled into the lungs. Your lungs are supposed to be a sterile environment. It's not meant to have anything extra inside of it. And so it can affect your lung capacity and your ability to saturate oxygen at the same rate that at a normal rate of someone who doesn't have that same assault to the lungs. And so that's what makes it so bad. 0% from an addiction perspective is great, right? Because they're lacking that addictive property. But from a health perspective, it's not really any better. It's just the point of this, as I mentioned earlier, is just the intent was for smoking cessation. So once you got to 0%, you would be on that dose for maybe a week to 2 weeks, and then you completely stop vaping. And so it was the way to wean patients off of nicotine and off of smoking. That's not what it turned into. Some people will stay on 0% forever, but they'll develop that. Some patients will develop that thing that I mentioned, the popcorn lung, which is that inflammation in the lining that's non-reversible. And so they'll have difficulty breathing. They may end up on oxygen ultimately, and it's not reversible. And so that is something that they'll live with for the rest of their lives.
Is there a risk of pneumonia associated with this particular route of consumption?
Of vaping?
Yes.
Yeah, anything inhaled into the lung, there's always like a risk of pneumonia associated with this. This is actually just like water entering into the lungs, which water is not extra water, isn't supposed to just be hanging around there. So there's certainly a risk of pneumonia associated with it as well. Okay, let's take a 10-minute break. Go out into the warmth, go outside or something where it's 4 degrees. Hello.
Yes.
I have a question. If the nicotine is metabolized in the liver by the enzymes agents, yes. That's kind of contributing to cirrhosis.
No, not necessarily. It won't contribute to some cancer. It'll increase the concentrations of nicotine, or sustain their concentrations of nicotine. If they smoke and they have cirrhosis, they won't be able to metabolize. So they'll just stay in their lungs. Kind of, it'll almost be like that genetic probably more prevention, where they won't be able to metabolize it. Like when metabolize it.
El de portfolio este. El de estaba en el portfolio.
Entiendo yo que
Yo no vi, yo hice todo los videos y me dio
y el portfolio
solamente me asignaron 3.
El de agua, el de portfolio y el de fondo.
y ya he traído presente.
No envié
¿Tú enviaste todos los certificados?
los 3 certificados.
Porque no me gusta lo que dice.
Hay un certificado que dice
I saw by the name.
Yes, yes. So you're from Ghana?
No, from Cameroon.
Cameroon. Oh, it's right next door.
Yeah,
And your name?
Nesh.
Nick?
Inesh.
Okay. Nice to meet you. You know, if you have any questions.
Okay, like by email or
Yeah, you can email me.
okay. So basically, the objective of your lecture.
It's my test questions. Very straightforward. I don't try to trick anybody.
Yeah,
There's no
so
point.
it's so stressful. So it's not
Yes.
good.
Yeah, I don't believe in that. So whatever's on the objectives, that's exactly what I will do.
Okay, thank you so much.
You're welcome.
Por eso tiene que ver.
What's going on?
Porque no son círculos pegados, son como almendritas. No, son yo lo veo como almendritas. Otra almendrita que hace como si que tú vayas a la casa y me quedo mirando mis 80 y no me ¿Qué tiene que ver este cartón que por ahí salió? Segundo bueno, obviamente, porque se nutrirá de aquí, si hay que ¿verdad? Está bien, Victoria, pero ¿verdad esto? Si el perro estuviera vivo y te lo pican, te lo dirían.
Wow,
Pero por las puntas se nutre el bebé. No, yo pensé que es aquí en el caso.
bueno, hay partes de tu cuerpo que pon el codo aquí y apriétatelo bien duro y a ver si te
Pero del pelo, del lugar. Supone que no duele. Pero pues yo creo
So now we'll go into part 3, the tobacco treatment approach. Did anyone have any questions about what I talked about earlier before we launch into this next section? Great. All right. So part 3, we're going to really talk about more so of the tobacco treatment approach, things that we want to consider, things that we do in preparation, and as we're kind of going through setting the patient up for success with smoking cessation. So first off, we want to start with the 5 A's. I believe you guys have been taught the 5 A's before. Am I correct? In care lab, correct? Great. So this is review for you guys. Most of this, the next few slides will be review. Some of this will be new. So remember, with the 5 A's, it's ask, advise, assess, assist, and arrange. And so with ask, we want to ask the patient if they are a current tobacco user. If they are, then we want to advise that the patient quits. And we want to utilize not scare tactics, but just information-based tactics. So we want to make sure the patient is aware of the health benefits associated with quitting. So I tend to recommend utilizing more so positive than negative tactics with this method for advice. So I don't want to say, I try to stay away from saying that like smoking is associated with high cardiovascular risk, or like high risk of COPD, and turn it into with quitting, you'll be able to breathe better. You'll notice that there's improved lung function or improved breathing in about 2 to 3 months. You'll generally feel better, your body will feel better, and it will thank you for it ultimately, and it'll decrease your risk of a lot of those concerning health factors that are associated with smoking. Right? Instead of saying smoking is bad for you because it's going to kill you, right? That terrifies patients. They're like, I'm so sorry. Why did you just say that to me? Like, I don't want to talk to you. I don't think that you're advocating for me to actually quit. You just seem hateful. And that's not what you want your patients to feel. It should feel like a safe environment for them to come to you with questions. So after we advise, we want to assess. So we want to assess our patient's readiness to quit, and we can utilize motivational interviewing, which I'm very sure you guys also learned a little bit about that as well. Great. We'll review too, but that's a big part of tobacco cessation. And so with that, we want to utilize those scales. Like on a scale of 0 to 10, with 0 being not at all and 10 being 100% ready, how ready would you say you are to quit smoking? And so obviously, depending on what they say, we use those motivational interviewing skills to kind of assess what those barriers are. But it's a really good way to assess their readiness to quit. If they tell you there are 2, then maybe and we assess what the barriers are. Maybe it's not the best time for them to quit. And especially if you're in the community pharmacy setting and you keep asking every time they come to pick up a prescription. We talked about this last time you came here. What has changed? Like now, on a scale of 0 to 10, where are you at in your readiness to quit? Each time you ask, it kind of it just allows you that moment to assess where they are and help them prepare for quitting once the time comes. And then we also have our assist piece. So once that patient is ready to quit, and they say, I'm feeling like a 9 or a 10 and I'm ready to quit, I just don't know what resources to use or how to get help with this, right? We want to assist the patient with quitting through assisting with like tobacco, setting up with a tobacco treatment facility or something like that, or a tobacco treatment specialist. And make sure that the patient is set up and has the resources needed to be successful in quitting. And then we want to arrange. So you want to make sure that you arrange some type of follow-up, not just say, here's this pamphlet, best of luck to you, bye. That's not helpful, right? Patients get overwhelmed. This is a big decision to quit. A lot of times it's a long history of smoking that they've had. And so it's going to be very, very difficult for them to quit because they might want to quit. They might have this desire to quit, but it's that addiction piece that makes it very, very difficult. And there's always high rates of relapse in this patient population because, we talked about the dopamine reward pathway, but there's more intricacies that I didn't really touch on. It's a little bit past what we should be talking about and for the purpose of being for NAP class, right? But there is this addiction component that happens within the brain as well, and there's a change in the brain plasticity that is never reverted back, and it's constant assault. And so some of this is a change in their brain that has caused this addiction that will always be there, no matter what. They've quit for 10 years, there's always that chance that they could relapse because of this change within the brain, within the BTA area specifically. So we want to make sure that we arrange some type of follow-up so that they're successful, because if we don't, chances are they either won't go through with quitting or becoming a non-smoker, or they won't, or they will likely relapse. Okay, so utilize your 5 A's. I find that this is specifically really nice in community settings. A lot of times for my particular My particular setting, I don't use the 5 aids very often, and if any of you guys in the future rotate with me, you'll understand why, but a lot of my patients, all of my patients, for the most part, there's a few that don't, but they all have lung cancer, and that tends to be their motivation for quitting, so that they're successful in their treatment and hopefully preventing any additional malignancies to arise as they're smoking.
So the motivation is fear of death because of the cancer.
Yes.
So what would you say from your experience? How can we determine earlier so that the cancer doesn't happen?
That's the question.
Can we use them probably as advocates to talk to people who don't have cancers now so that they can probably get people to stop before they get there?
Yeah, that's a really great question. You can. So, you guys see any of those fun commercials on TV that talk about like this is what happened when I got cancer or from smoking? Yeah, so that's the goal, that those type of commercials will hopefully persuade people from smoking. And they'll understand that like this could happen if, now depending on how far they are into their smoking, those commercials are like, that's really unfortunate for you, but I'm fine. And so that's where it's very difficult, right? Like patients are like, okay, I'm so sorry that you now have a breathing tube, but like I don't. So it seems like there's just bad luck. But really in reality, it's anybody could get this, right? You could get this. So it's a good point. You could utilize patient advocacy. One thing that I do in my smoking cessation clinic, we do have an interventional pulmonology clinic that happens as well. So I try to intervene earlier on before it hopefully progresses, gets to that point where they have lung cancer. The interventional pulmonology is just essentially like lung cancer screenings, which we'll talk about briefly in this lecture. But if they have any type of suspicious nodule that we don't think is necessarily cancerous but could progress to such, I'll intervene there and say, hopefully we can reverse some of this and that nodule will go away on its own or it'll stay stable and it won't continue to grow. If we stop early enough, we can either reverse it or they monitor it and they're able to, if it starts to grow and looks kind of suspicious for cancer, they can cut it out. That's 100% cure for lung cancer. We'll just get rid of it and cut it out. Anything else is not necessarily 100% cure. There's some caveats to that. So there definitely are some benefits of intervening very early. Okay. Any other questions? So 5 days, very important. We also have our Ask, Advise, Refer process. And so this is more so what I utilize in my clinic. So ask the patient if they're a current tobacco user. For the most part, I do that via chart review. So I can go into the patient's chart, review if they're a current tobacco user. If they are, then I will go talk to them and advise that patient to quit. I will say, this is my tobacco cessation program that we have here over at our hospital. I see that you're a current smoker. Can you tell me a little bit about your history? And then utilizing that motivational interviewing, asking on a scale of 0 to 10, how ready are you to quit? And then kind of assessing where they're at. They're there for interventional pulmonology. A lot of times the pulmonologist will try and intervene early and say, I really highly advocate that you quit for X, Y, and Z reasons, particularly because I'm concerned about this nodule that we saw on CT. And so I will step in and help aid in that process as well. And they will often be referred to me, or I will refer them after talking to them and say, based off of what you told me and your readiness to quit, or at least starting to make their steps to quit, I recommend you enrolling into our tobacco cessation program so that we can kind of get everything set up and get you prepared for when you set your quit date, you're ready to, really take that step forward and quit. So referring the patient to a tobacco treatment program, whether that's a provider or like an in-person provider visit or a telephone-based visit, whichever mode of communication they want to utilize or that's best, then that's what we go with. Mine is hybrid, personally. Any questions? So as we talked about earlier, we talked about kind of like what were some of the health implications of tobacco use. With tobacco cessation, remember I said when I talk to patients about that advice piece, I want to make sure that they know about it from a positive perspective. So these are some of the things you can utilize. Because these are some of the health benefits. You can say that it improves your cardiovascular health, so decreases your risk of peripheral artery disease, decreases your risk of hypertension depending on how far they are into their smoking cessation or into their smoking history, and things along those lines. It improves your lung function. So like I said, when patients quit smoking, usually between 2 to 3 months after quitting, they'll tell me, I feel like I can breathe so much better. I didn't realize what was happening. I've never breathed air like this before, or it's been a very long time since I felt like I could take such a deep breath. So even in patients that have things like COPD that are chronic, they'll even have some lung capacity improvement. Their O2 stats may improve a little bit. Improved mental health. So I know that earlier I mentioned that patients will say that they feel irritable and anxious. But this is just a short-term withdrawal symptom. Over time, that improves. And often patients that have any type of mental health disorder, they tend to say, I actually feel better. I feel less depressed. I feel like I have less anxiety. I generally overall just feel happier. And so for patients that have any of these disorders, initially, it is very hard for them. They will say, I can't do this. This is making my depression worse. This is making my anxiety worse. But with encouragement and behavioral therapy and things along those lines, that you'll find that over time, usually 4-ish months, 4 to 6 months, patients tend to say, I feel much happier and I feel better. And so they have improved mental health outcomes. They also have improved outcomes in oncology treatment. So tobacco smoke or cigarette smoke actually interacts with a lot of our chemotherapy medications. And so for that reason, we encourage them to quit so that they have the best outcome possible when they're going through treatment. And so for that reason, we'll see better outcomes in oncology treatment. The other thing is when you quit smoking, it also decreases your risk of secondary malignancies. If you continue to smoke, you could develop recurrence of your lung cancer. Let's say that's what you have, but remember I also mentioned it can cause things like bladder cancer, cervical cancer. So when we quit, it can decrease your your chances of some of these cancers. And then it can also improve surgical outcomes. So like I said, remember there's cardiovascular risks. Because your cardiovascular because of the vasoconstriction, it can cause difficulty with wound healing when patients are smokers. So actually, for my patients that have lung cancer specifically, a lot of our surgeons won't do surgery. They said unless the patient will quit smoking, I don't recommend this because the healing process will be very, very difficult for them. Some of it has to do with maybe they have really bad vasculature at baseline, but the other issue is that the wound healing is a lot slower. Like I mentioned, let's say the patient's diabetic. Smoking itself can cause insulin resistance, like I mentioned, so it just makes it a little bit difficult for patients to have really great outcomes when it comes to their healing with surgeries. So these are some of the benefits that you can utilize when talking to patients. So, any questions about this? All right, so when we get started, we want to do an assessment. So I do like a pre-assessment. I go through their chart, I assess kind of where they are. If you have that ability to kind of go through their chart and see some of their medical history, it can be helpful. But the other things that you want to consider before we get started is how am I going to assess this patient? So are you going to do it electronically? Are you going to provide them with like a paper sheet? So sometimes we'll do like an intake form that will go over some paper, like some certain questions. I do electronically through like a note that I'll create with questions that we'll go through together. But you have to know, how am I going to assess this? You don't want to just walk in and be like, I'm going to ask you about your questions. Well, where are you going to document this information? At some point, you're probably going to want to come back and kind of read through that. And so making sure how you're going to complete this is important. And then where is this assessment going to be completed? So are you going to do this at like an initial visit, during some type of interview process? Are you going to do this before they have their initial visit? So you call them on the phone before they come into clinic and you do this assessment. Or are you going to do this via a patient like portal system where they can fill out this assessment prior to coming in, just so that you can see what they have, what their answers are to the questions, and assess it before they come in for your visit. Whatever mode you use, that's totally fine, but you just want to be sure that you pick one to make sure that your assessment is successful. Some important components of your clinical assessment, you want to get demographics, you want to get tobacco use history, so it's really important to have an understanding of their tobacco use. How many years have they smoked? How many packs per day, and on average have they smoked? And things like that. What age were they when they started smoking? That's really important, because that will go to show some of the important things associated with dependence, or how dependent they are in their smoking. Because the younger they are with their tobacco use history, obviously, typically they have a higher tolerance, which can make it a little more difficult to quit. Not impossible, but definitely a barrier at times. The level of tobacco dependence. So, like I said, there's varying levels, and there are different validated tools that you can utilize to assess this, and we'll talk about one of the ones that's most commonly used. But we want to know the level of tobacco dependence. We also want to understand their social, cultural, and environmental factors, because we want to be culturally sensitive, but we want to also be mindful of their environment. Do they live with other people that are smokers? Do they smoke? Where do they smoke? Do they smoke inside of the house? Do they smoke only outside? Like, where will they not smoke? That's not a question I often ask. Where are places?
Sorry to interrupt.
No, you're fine.
So, for example, if you have like a lung cancer patient and his wife smokes, for example, or his spouse smokes, will you like try to treat both of them at the same time, or only treat the patient? Because like, for example, if I go home and I'm trying to quit smoking and my daughter or my spouse or whichever person is smoking, I'm gonna see that possibly it's gonna be a trigger. I've been smoking for 30 years, so like there's a high, I think, relapse rate. So how would you treat that? Would you treat like both of them, or just treat the patient as itself?
So typically in my clinic, I only treat the patient. Part of it has to do with resources. But the other thing is that I put the ball in the patient's court. If they think that they can quit knowing that their spouse is still smoking, then I allow them that opportunity to try, but I do encourage them to have those conversations. Like, for example, sometimes if someone will say, oh, well, I see her smoking across from me in the living room, I often will say, well, what are your thoughts on talking to her about smoking outside? And having that conversation, although it's not fun, no one likes having difficult conversations, it's important for your health. And hopefully you can advocate for his or her health as well, that it's important that they quit, because look at what you're going through, right? And so a lot of times I actually have spouses that are like, I'm quitting too. Like, after this happened to them, I'm gonna quit. And so I'll give recommendations, obviously, to the patient. The spouse will, most of the time that I've seen them, the spouse has already taken steps to also quit. So seeking out pharmacotherapy agents and signing up for their own tobacco treatment program and things like that. If they don't, then I'm also happy to provide some assistance, but my main focus is on my patient. Yeah. So just making sure they also have those conversations with their spouse, so that hopefully they're understanding, right? If your family member cares about you, then often they're very receptive to your asks of, like, would it be possible for you to smoke outside? Somewhere else where I don't see it or smell it, and I don't have those triggers.
I'm also going to say, I think the secondary smokers, where you're sitting around somebody who's smoking, you are not smoking the cigarette, but you're actually inhaling. So that probably might also be a challenge for them, even though they maybe say they don't want to smoke, but they need to know that sitting in a place where smokers exist automatically puts them at risk, because they're also inhaling the same amount of
Yeah. So yes, a secondhand smoke is definitely not great. And it's true, I always advocate, hopefully, like, your family member is understanding enough to know that, they shouldn't smoke around you, because secondhand smoke does pose its own health risks as well, and challenges. can put patients at risk of developing those cancers and whatnot. Usually the risk is a little bit lower, but it still exists. And so it's important to advocate for that as well. Agreed. Let's see, so environmental factors. And then I also will go through the importance of quitting, their motivations for quitting, and their confidence. So how, and I utilize motivational interviews viewing to assess this. On a scale of 0 to 10, how motivated are you to quit? And on a same thing with confidence. And then I will also take a med history. It's important to know what medications they are on because, like I said, there are some drug interactions we want to be mindful of. Because, like I mentioned, yes, tobacco or nicotine is metabolized by the liver, but the drug interaction itself doesn't come from nicotine. There are some drug interactions with nicotine. I'm not going to say that there are 0. For example, there can be a drug interaction with caffeine. So I have to tell patients, if you drink coffee, I want you to be mindful when you quit. Maybe right now you're drinking 6 cups of coffee a day. You will not be able to do that. Or chances are, I'm not going to say you can't. Anything's possible. But you may feel more jittery because caffeine, because nicotine can decrease the concentrations of caffeine. And so it's important that they know these things ahead of time because sometimes the patients, when they get jolted with surprises, they're just like, never mind. This is terrible. I don't want to quit. You didn't warn me this is going to happen. So I try to give them as much preparation as possible. And so I take a med history so I can also understand what implications we're going to have with their medications. Are there any drug interactions with the pharmacotherapy agents I'm thinking about starting them on? Are there any drug interactions now with any of the medications that they're on as it pertains to smoking or to cigarette smoke itself so that we can monitor those things and maybe consider decreasing or making changes to the doses. Like I mentioned, we want to do an assessment for dependence. And so, like I said earlier, there is a validated test that you can utilize. That is called the Bakerstrom's test for nicotine dependence. Sometimes you'll see it abbreviated as FTND. It's a, like I said, validated standardized tool that assesses a patient's physical addiction to nicotine. It's designed to measure dependence. So it will tell me how dependent is this patient, which will equate to how difficult will it be for them to quit. Not impossible, but it just means that we might have to use some different techniques and tactics to help aid in their tobacco cessation. It is not a diagnostic tool, so it doesn't tell me anything more than this is how dependent they are, which can help me correlate to kind of like where are we starting at, but it will not diagnose them and say like, you scored a 3, and so therefore, I'm diagnosing you with a dependence of like a high dependence, and therefore this is what you like. It can't do anything like that. It's just helpful in aiding to understand dependence-wise where are we at, and give me an idea of what maybe some recommendations could be to help with their tobacco cessation. And so with Bakerstrom's test, this is some of the questions. Now, there's a short version and there's a long version. I utilize the short version, which is usually about 3 questions. The long version, I think, is a long time since I've seen it. I think it's 15 questions. It's quite long. And so it's based on a point system, and every question has a certain amount of points associated with it. So as you can see, the questions include like how many cigarettes do you smoke per day? So I ask that question for all of my patients. And each one of those are associated with a point. Then I ask, how soon after you wake up do you have your first cigarette? That is the most important question to ask in this assessment. This is the number 1 question that leads to how dependent are you, right? Because if someone tells me that they smoke within 5 minutes of waking up, you have a high dependence. But if you tell me, oh, I get up, I shower, I go make a coffee, I take the dogs out, and then I'll have a cigarette. Usually that means it's probably close to an hour, and you have a much lower dependence. It's probably going to be a little bit easier for us to get you to either wean off or completely quit with your given quit date. Other questions that you can see on the Bakerstrom's test include Do you find it hard to refrain from smoking in places where it is forbidden? This goes to another question that can help with dependence, because if patients say, like, it's very hard for me not to smoke on an airplane, where you obviously can't smoke, then that means that you definitely have a higher dependence associated with smoking. And then other questions are like, what cigarette would you hate to give up the most? Do you smoke more during the first hour of waking? And do you smoke if you are too ill to get out of bed? Those are all questions that can help decide or help dictate some of the dependence factors and components. But the biggest one is, how soon after you wake up do you have your first cigarette? That is the number one question that if my learners don't ask any of the questions, that's the one that I'm like, if you didn't ask that question, you're gonna have to go back. And then you can come back and we can assess. But until then, it's very difficult to understand. The other thing is that that's a very important question for one of the nicotine replacement therapies that we'll talk about as well. If we don't have that information, then I can't make any dosing recommendations either.
So how would you classify a patient who says, I get some 60 minutes or more before they start smoking, but maybe they would do like 5 months?
That would be one, very impressive. And two, I would say that they have a higher dependence. They would score very high in the smoking, how many cigarettes do you smoke per day, which would give them a total higher number for dependence. It's very rare. I've never seen that. Patients that smoke that many cigarettes, even, let's say five is extreme. You'd be smoking a couple every hour. But yes. Oh, that's common. Of 1 pack every hour?
Yes.
Oh. Wow, that's impressive. Were they smoking them all? Or like some patients will say, oh, I smoke a pack a day, but they just let it burn.
I got something else.
I want to be here. and just, oh, you did? Hey, I love that for him. Wow, 1 pack every hour. I bet he saves so much money. That's, for me, I tell my patients, I'm like, this is expensive. Like, when was the last time you went on a cruise?
The guy stopped.
Good for him. Tell him I said good for him. Oh, I love that. Typically, patients that smoke higher numbers of cigarettes like that, they usually have a higher dependence. I am very shocked if they tell me they go an hour. That's almost impossible. For them to keep up with that much cigarette consumption, they have to smoke a cigarette as soon as their eyes wake up, basically. And I have patients that are like that. They are 2 pack per day, and I have patients that say, I ask, how soon after you wake up do you have your first cigarette? They say, as soon as my feet touch the ground. And I'm like, okay. That goes to show high dependence, right? So I'm like, oh, okay, you've probably been smoking for about 45 years, 2 packs per day, and that's something that we'll overcome. But we set goals and talk about some benefits. Like I utilize things like, oh, with all that money, what's something that you would really like to do, right? Because it's very expensive. And I'm like, yeah, it's so expensive. I'd love to go on a vacation. I love that. Where are we going? When we talk about that, we set that as a goal. We say, each day that you don't buy a pack of cigarettes, remember, put that money into a jar and look at a year, see how much money you're saving. You're going on a cruise. Just let me know where, so we can celebrate together and take you with you. But anyways, so yes, dependence question is very, very important. Scoring, like I said, so the score is from 0 to 8. Generally, 0 is very low dependence. There are patients that smoke less than 10 cigarettes a day. And sometimes there are my patients that are probably slow metabolizers. And their smoking habits come from just that habit that they picked up when they were young, and they just stick to their 5 cigarettes a day. And they don't ever go past that. But the score is 1 to 2 is low dependence, 3 to 4 is moderate dependence, 5 to 7 is moderate to high dependence, and 8 and above is high dependence overall. For the modified Frankenstein's test, it's usually 3 plus is a high dependence.
Okay, this would be for normal metabolizers. If the patient is an ultra high metabolizer, it would not be anything.
Yes, but usually from that perspective, if I see greater than an 8, I would assume that they're probably a rapid metabolizer. I don't ever do genetic testing primarily because it's expensive. And it's not gonna change how I treat them. Like, you can assume if they're greater than an 8, it's either that they have that they're either a rapid or a fast metabolizer, or they just have a very high dependence, which it may not be genetic. Okay, now with our assessment, I treat it like a vital sign. So every time you go to the doctor, they get a blood pressure and a heart rate of this, that, and the other, same thing. Every time you see a patient, especially if you know they have a smoking history, you ask them and assess their readiness to quit at every visit. Because that is how we make those differences. That's how we get patients to get to that point where they are ready to quit. And it's not to be nagging, it's not to be pushy, but various things that happen in a patient's life will push them to want to quit. Sometimes that's, I just had a baby and I quit while I was pregnant with her, I started again, but for her health. I don't want her to develop any pulmonology or pulmonary issues. I want to quit smoking. So their motivations change over time, and that is why we ask at every visit, because today they might not want to quit, but tomorrow their best friend could have gotten lung cancer and they're saying, I'm going to quit with her out of support and out of being mindful of my own health. Pack your history. Great. Pack your history. Very important, not necessarily from a treatment perspective, but when you're talking to patients, something like I said, the number one thing that I want us to be mindful of with smoking is that patients can develop lung cancer. So obviously, the more they smoke, the longer they smoke, the more they increase the risk of developing some type of malignancy, but specifically lung cancer, because that's the number one cancer associated with smoking. And so with that, we want to be able to say, do I think that she would benefit from a lung cancer screening? Now, obviously, the question might be, why doesn't every smoker just get a lung cancer screening? Well, there have been studies that have been done that have shown that patients that just willy-nilly get, a lung cancer screening, they often are misdiagnosed. Because lung nodules on CT scans, they could be cancerous, they could be infectious. You don't know. And so you don't want to go inherently just doing like a biopsy that has its own health risks associated with it if you don't need to. I don't want to go in and do any type of surgical intervention if I don't need to. And so for that reason, there are guidelines or guidances outlined to help you as a clinician or as a practitioner say, okay, if you hit this number, then I think that you should go get a lung cancer screening. And so first thing that we want to do is calculate their pack-year history, because that's going to be very important. That will let us know whether or not they should be referred out to for a lung cancer screening. Now, to do this, it's just as you can imagine, it's the number of packs of cigarettes a patient has smoked in their lifetime. And we quantify this as packs. So usually we'll say, did you smoke a half pack, 1 pack, 2 packs? And this is just an estimate, understanding that their smoking habits can certainly change over time. So a patient could say, oh, I smoked 2 packs per day since I was 12. And so you'll just calculate whatever their current age is, like that year, minus, the year that they started smoking. And multiply that by the number of packs per day that they said they smoked. Certainly that can vary, so maybe they'll say, from ages 12 to 30, I smoked 1 pack per day. From 30 to 75, I smoked 2 packs per day. So that might require a little bit more math. But generally, we want to calculate their pack per year history, or their pack year history. And like I said, this will let us know if they are a candidate for a lung cancer screening. So there are 2 guidelines that have dictated what they think or when or who qualifies for a lung cancer screening. So that's the American Cancer Society, and then the NCCN guidelines, which is the National Comprehensive Cancer Network. They also have their own set of recommendations. Now, the American Cancer Society, they recently updated their recommendation in 2023. And they say now that for patients that are ages 50 to 80, and are either a current or a former smoker, regardless of when they quit. So even if they said, I quit 20 years ago, but you still calculate a pack year history of greater than 20, and they're in that age range, we recommend a low dose CT. And then the NCCN, they have a similar recommendation, but they just say all patients that are greater than or equal to age 50 and are current or former smokers and have a smoking history of greater than or equal to 20 packs, pack year history, or greater than 20 years of smoking history, should have a lung cancer screening with a low dose CT. Computated tomography is imaging, so they'll go in and scan your chest.
So in the case of American Cancer Society, after 80 is not necessary.
That's what they're saying. Now, it depends on who you ask, it depends on the pulmonologist. Some of the reasons that they say this is just because this is how it was studied. They didn't have anyone in the study greater than 80, and that's why they cut it off at 80, but there's no reason. Some people say that they don't think greater than 80 is, they need to, because life expectancy, essentially, is it worth going in and doing all these surgical procedures for somebody who's 85 or 90, depends on whatever their wishes are, right? So some people will follow the American Cancer Society, some will follow the NCCN. Generally, I see the American Cancer Society recommendations utilized more frequently. That's partly or mainly because they're updated more often. NCCN updates their guidelines yearly, but the recommendations don't change drastically. Usually the ACS recommendations will change a bit more drastically. Okay, any questions about lung cancer screening? And it's really important to advocate for these for patients. A lot of patients will not get a lung cancer screening, and then they get to us and we'll find out that they have stage 4 cancer. And it's really unfortunate because we'll say, did you ever have a lung cancer screening? And they'll say, my doctor had recommended one for me. And it's given your smoking history, you should have had one, right? So really important to calculate this because at least we can advocate for them to get one of these, even if they're not quite ready to quit. You can say, okay, you should at least get a lung cancer screening. If you're gonna keep smoking, you wanna be mindful that you don't develop lung cancer.
What was it, 20 pack year history? That's 20 packs in a year.
That's the total number of packs that they smoked in a lifetime. That makes sense? Okay. Pack year history is we ask the patient, how many packs on average have you smoked per day in your lifetime? So they'll say, oh, I've smoked 2 packs per day for the last 4 years, right? And then we multiply that by how their smoking history. So how long have they been smoking for? The patient said 40 years. So I will multiply 2 packs per day times 40 years. And that will give me a total of 80 pack year history. Does that make sense?
Okay. So give it like half a pack a day. How often that's 20?
Yes. So if they did half a pack per day for 40 years, then it's 20 pack year history. Make sense? All right, this brings us to our knowledge check. So which of the following questions on the Fingerstrings test is best at assessing nicotine dependence? A, do you find it hard to refrain from smoking in places where it's forbidden? B, do you smoke if you are too ill to get out of bed? C, what cigarette would you hate to give up the most? Or D, how soon after you wake up do you have your first cigarette? D. D? Perfect! Love that! Oh, you guys are listening. Great. So how soon after you wake up do you have your first cigarette is the most important question to ask for dependence, and it will also be helpful from a pharmacy perspective on dosing as we talk about things. Now, for patients that are unwilling to quit, we want to utilize the 5 R's. So relevance, risk, reward, roadblocks, and repetition. So relevance is why is it important to quit? for them. You know, every person has their reasoning for quitting. The risk. So what are the risks to continuing to smoke? These are questions that you want to ask the patient, right? Because I want to get an understanding of like, what's your understanding of the health implications, or why would you want to quit? Tell me, you know, and that's when we can utilize that motivational interviewing. Reward, what are the benefits of becoming a non-smoker? And roadblocks, what are the barriers to quitting? So what barriers do you see for quitting? And sometimes we can get that from just utilizing motivational interviewing. You know, why would you say you're a 3 for quitting versus a 5? And we can understand their barriers to quitting. And then repetition. You want to repeat this at every treatment visit. So like I said, I treat our assessment like a vital sign, and so we ask at every visit. We want to repeat these questions or going through these 5 R's at every visit, so we have an understanding as to what their barriers are to quitting and how can we help them overcome them. Now with the smoking, yes.
I did it 120.
Oh, 120? I am so sorry. Yeah. Okay. Great.
Is it tomorrow?
Yes. Tomorrow it is. You're welcome. If you guys have any questions. I will be here tomorrow.
Thank you.
Yeah, of course.